There have been absolutely loads of changes that have happened in the past few weeks when it comes to general practice and basically the way that we live and work due to the Omicron variant and COVID and a few other things. And in this episode, we're going to cover everything you need to know about the change to general practice, QoF, vaccinations, Plan B, and so much more. This is our EGP Learning mega update. And as you can see, we're back together. So let's tech enhance your primary care and learning. Hey GP learners, welcome back, and we're getting started with our mega update, which hopefully will give you all the information you need to know about all the changes in general practice. As you can see, me and Andy are doing this face-to-face. That's partly because I've got some issues at home. We're trying to sort it out. Just to clarify, both LFT negative, vaccinated, and as you can see, we're wearing masks as well with ventilation and stuff. But how are we doing there, Andy?
Yeah, not too bad. Mega update episode. I think we've built the expectations quite high, Gandhi. I don't know if we can deliver, but we'll have a go.
We'll definitely give it a try. And just to mention again, as we said, so in this episode, we're going to be covering all the changes that have come in terms of QoF changes for general practice, the vaccination schedules and stuff that are happening, as well as various other changes that are happening, including Plan B, and basically whatever else we can squeeze in as well, isn't it, Andy?
Yeah, so I think the thing that's been occupying most of my attention as Primary Care Network Director towards the end of the week are the letters that have come out about changes to QoF and IAF indicators in relation to, or not in relation to, sign up of practices to the phase 3 COVID vaccination enhanced service.
Yes, exactly. And one of the things we're not going to cover in absolute detail are the changes to the vaccination payments that happened. So that came out about a week or so ago. But basically, most people are probably aware that the amount being reimbursed to practices for delivering the vaccinations has increased. I think it's now £15 per jab instead of £12.58. And there's an extra uplift for housebound and care home-based patients as well, particularly if you end up doing it the weekend. And that's clearly with a view to ramping up the vaccination schedules, which obviously the time frame for the boosters has been the big modifying thing, with obviously that going down from 6 months to 3 months. We're not going to cover that part in detail, but what we are going to cover is the QoF stuff and all the other aspects of change that you need to know about.
And it may be just worth taking a brief step back for those people who've been living under a stone and not paying attention to media in the past few weeks. Gandhi, what's the reason why there's now increased pressure and to accelerate the vaccinations?
Sure. So obviously about 2.5 weeks ago, the Omicron variant became more public. And obviously it's the unknown factor of how this is going to change things for everybody else. What we do know about it is it's considerably more infectious than the previous variants like Delta and stuff. Symptom-wise, what that means, it's still a little bit unclear. There are some musings about the fact it's not as severe in terms of the way it affects people compared to things like Delta. But obviously the fact that it's a considerably more infectious variant and the risk of that being at winter time, general practice is under strain. Hospitals massively under strain at the moment. I think clearly they're being cautious. And actually, it's nice to see them being cautious about it for once, rather than just saying, do what you want kind of thing.
Yeah, the response has been much more proactive to the emergence of this new variant than it has been to previous new variants, which I think is encouraging as well. And you make an important point that even if this does turn out to produce milder symptoms, some people will still get unwell. Some people will still need hospitalization, and some people will not do well at all. And if it is more contagious, and that definitely seems to be the fact, then actually the number infected at any single time will be greater. So even if it's less, even if it's milder disease for individual patients, the strain on the healthcare system could still be enormous, and it could still break the NHS throughout the winter. So that's why there's a focus on getting more people vaccinated more quickly. So that's how we got here.
And then the added point about the vaccine escape element. So obviously we don't know how well the vaccines will protect people against Omicron compared to the other variants, and that's the other mitigating factor. We're hearing stuff about AZ seems to be fairly good at protecting, but Pfizer, you probably need your booster jab in order to have better protection against Omicron. Again, the severity is the unknown part.
But it's nice to see people moving quickly about it. So we've had a few letters coming out. So you were talking about the earlier letter, which spoke mainly about payment. And then on the 8th, we had some clarification about the pausing of certain indicators and work for general practice and the protecting of certain incomes to enable general practice to focus its efforts on getting more people vaccinated more quickly. I suppose prior to all of this, we'd had changes in the objectives and aims around vaccination to reduce the interval from your second vaccine to your booster from 6 months to 3 months. That was the biggest change. Looking at we have a weekly meeting in the primary care network that looks at the projected numbers of people that we need to invite each week. So we went from inviting, needing to invite a few hundred people, say last week, to needing to invite about 4,000 people in 1 week, just because that's what it did to our figures. So we had to relook at how we're going to profile those invitations in the coming months. So it's caused, a lot of work, and you can see how the reduction from 6 to 3 months translates into increased pressure on general practice in the NHS to get those vaccines in arms. And actually, that's the reason why there is a necessity to free up time in general practice by pausing some of what might be considered less vital regular work. So that's how we got here.
Yeah. And people are probably noticing me typing in the chat. So if you do want to give us your comments, we'd love to hear it. So I've asked the question in the chat, and let us know either thumbs up or thumbs down. Are you planning on changing your vaccination plans in terms of what you're doing either in your practice or your network? We're going to cover what that potentially means if you are or are not in a second. But yeah, absolutely, the volume of people going up has significantly increased. I know in my network, prior to the changes, we were told 6,000 patients we still have left to vaccinate in our population. That's now quadrupled to 24,000. So yes, massive numbers, and clearly there needs to be changes in order to support that. So let's talk about those changes, shall we, Andy?
Yeah. Absolutely. So there was a letter that landed, I think it was on the 8th of December, so just a few days ago. I believe that was Thursday, or maybe it was Wednesday, that provides clarification about these changes. So should we spend some time with that document
Absolutely,
and go through?
So if you want the link to this letter, it'll be in the chat when we finish, but it's called the Temporary GP Contract Changes to Support COVID-19 Vaccination Programme. Letter came out on the 7th of December, so that's 4 days ago from the date we're recording this. Slight apologies, because we're recording it 4 days later, a couple of the deadlines have already lapsed. So they were yesterday, but hopefully you should all be aware of these, but we're going to cover what that potentially means. The key thing that everyone is talking about is the suspension of QoF, which is what this document outlines, both the specific criteria relating to that. And it's basically effectively in 3 parts, isn't it, Andy? There's stuff that you still have to do. There's stuff that's being combined into other things, and then there's stuff you can stop doing, sort of, is probably the best way of describing it. And we're going to go through that in a bit more detail. The main letter outlines the key changes and why they've made them. And as Andy mentions normally every time, it's a good summary as such, isn't it? But it's a bit light on the detail.
Yeah, this document provides more clarity, particularly in the appendices, which is normally where the action is. I'm beginning to learn in these documents that come out. So if we just start to look through the first few paragraphs, are really just introducing why this has happened, and then we begin to talk about the areas of QoF which have been paused, or so actually I think we'd say what's continuing first of all, actually. So unchanged by this letter are the areas of vaccination and cervical screening, and also many of the prescribing indicators. And we'll look at those in more detail when we get to the appendices. There are also 46 prescribing indicators which are new. There isn't historical income to historical figures to reflect on, but we are expected to perform against those.
Yes, so just to clarify, that says 46 points that have no historical things for them to give you, because obviously this is about paying you based on historic data. So there's 46 criteria, and we'll come to those in the appendices. There's no historic data. So rather than saying you still have to do them, what they've done is they've taken those 46 points out and they've rolled it into the prescribing indicators. So basically your prescribing indicators are probably now worth a lot more than they were before. So important to be aware of that, and we'll cover the exact numbers in a minute or two, so definitely stick around for that.
Okay, and then remaining indicators are going to be protected based on incomes in what seem to be the most appropriate years for those incomes being recorded. So some are from 2018-19 and some are from 1920. So, and we'll get to the details of that when we get to the appendices where the nuts and bolts are, essentially. And then there are some implications for the impact and investment fund. Do you want to talk through those, Gandhi?
Yeah, so impact investment fund. So this is the one that many people kind of consider as the PCN version of QoF. And again, there's some criteria that are continuing, and there's some that have been suspended, which is the terminology they've used, which basically means you don't have to do the work, but you kind of still do. But the payment for the work is going to be protected. So the vaccination parts of the impact and investment fund, so pretty much the flu vax ones, that's still continuing, and you will be assessed based on in-year performance. The binary version on terms of the GPAD appointment data program work that law practice has been doing, that is continuing, but I believe that's just because they've already paid it. So a lot of networks have actually already had that money, so that's why they've said it's still continuing, because it's work you've already done. The others, and pretty much all the other IF points, are now suspended, but how they're then allocating that fund is a little bit different.
So yeah, just talk about that, because this is now, I must admit, I still haven't fully got my head around what this binary indicator means and where the money's come from to roll into it, and whether that's been taken from other places. So
yeah, so these are some of the indicators that we've talked about in some of our earlier streams that came out around about October and stuff. So this is I can't remember everything off the top of my head, but a variety of different indicators in terms of hypertension monitoring, asthma, inhaler prescribing, all those kind of things. So they've suspended all of those, and basically they split it into two parts. So it comes up to a total national pot of £112.1 million. Out of that pot, £62.4 million is going to be badged as PCN support. So this is for basically helping you do the vaccination schedules, as far as I can see. And the key thing with that is that money will be weighted. So it's based on your weighted population, and it is specified for the reinvestment of services and workforce. What monitoring is going to happen to ensure that? No detail. Okay, the document's only just come out a few days ago, fair enough. But just to be aware that you will get some of that back as PCN support, but it's going to have a designated use for it. So just to be aware of that. Any questions on that one, Andy?
So the question. So in my primary care network, we're a little bit unusual, as you're aware, and people who've been following the discussions we've had about this are aware. So we have a collaboration with a community pharmacy, a really big vaccination centre that was there prior to the phase 3, that does a really good job and puts jabs in arms of really high volumes of patients. And the practices invite patients. So we use the data we have on our clinical systems to select the right patients and invite them and chase them and get them to appointments at that vaccination centre. But we're signed up under the community pharmacy vaccination scheme. So our area is not signed up to phase 3, but we're being very successful in delivering the jabs. So the main thing for me is to understand what this means in my circumstances, because we're not signed up. So my question, Gandhi, and I think I've worked it out, but what elements of this would my practices and my primary care network be eligible for or not? So clearly, in your interpretation.
Yeah, okay. So firstly, I'm not NHS England. We're going to say that. Sorry. But the second part of that fund, the 49.7, is potentially the one that you may or may not be eligible for. So this is a proportion of that rolled up 112 million that you will get if you're signed up to phase 3 COVID vaccinations. Now, whether you're eligible or not, Andy, honestly, I can't tell you. That's what NHS England are going to have to say. Logic would say if you're doing work to support the increased vaccination of the populations, then you should be awarded that. And based on our really basic calculations that me and Andy have tried to do, for an average population PCN of 50,000 patients, this pot of money is approximately just under £50,000. That's not taking into account weighting, so that's why it's a very rough estimation, and it's simply just population in UK divided by 50,000 patients times by the amount of money that they say is. So that's where we've got to that figure. If we're wrong, please tell us. Let us know in the comments and stuff. But if you're not signed up for delivering the phase 3 COVID vaccination, your network is possibly losing out on that amount of funding. Important point with this, I think there's been some confusion in some areas about this, meaning that people have thought they're not eligible for the QoF support. And I wonder if some areas, ours included, may have misinterpreted that to say that if you don't sign up to the vaccination things, then you can't get the QoF support. The BMA have been quite clear that every practice is eligible for the QoF support. But I think the IAF part, this part, is the one that if you haven't signed up, you may not be eligible for.
I would agree with your interpretation, Gandhi. I mean, we're in some discussions with locality team and the CCG just about what this means for our specific circumstances and our primary care network. I think the previous letter to this was a little bit less clear about the eligibility for these pauses and breaks for practices and primary care networks. This one is more clear, and actually the measures actually seem quite reasonable. And I know a few weeks ago people were, particularly when the expansion of the vaccination program was announced, people were saying, what about QoF pauses? What about IIF pauses? What about protecting income? And actually NHS England have come out and delivered fairly well in that area.
They have.
I would say we're sometimes critical of what they do, but I think this is quite positive and balanced.
One thing it does say is that you do need to continue recording your activity. So although the payment is protected, it still does say for you to continue recording stuff. And I'm assuming this is just so they've got something to do for next year more than anything else. And possibly some monitoring elements of things, just seeing how networks and things are doing. But just to be aware, it does say you still have to record the work. Obviously, how much work you're doing, that may vary. There are some additional minor kind of inclusions and stuff. So, and we're going to talk about the wider measures as it's called here. So number one is minor surgery. So your minor surgery income is protected from the 1st of December till the 31st of March, as long as signed up for vaccinations. And it does state that the capacity that you would have from not doing minor surgeries is then rolled into the vaccination scheme. And I suspect that they will want some proof of that at some point. So just to be aware of that. In terms of protection, it's based on the figures from 1st of December 2018 to March 19. So whatever work you did for minor surgeries in that time frame is basically what you will get for this one. Is that clear?
That's clear. I understand that. And again, it's nice to see, and also there's an option to pause over 75 health checks as well. But I think where you feel that this is clinically appropriate, with those sorts of caveats, which I think is reasonable.
So interestingly, when that one came out, a lot of people were surprised because I don't think a lot of practices were actually doing the over 75 health checks.
That's interesting. I've had a few conversations along those lines as well. So that was quite interesting. It does make clear that there's over 75 health checks are deferred, not stopped. So I think there is the expectation that you will still have to do that workload when things open up, whenever that may be. And then the final one is about the dispensary services quality scheme. So this is for dispensing practices. It just changes the amount of patients you need to review down from 10% down to 7.5%. So, that is an additional offer that you've got. And then finally, there's the additional telephony support part. So this is an interesting one. This came out in the Winter Access Fund document a while back. And it said that there was going to be some work looking at supporting practices with telephony. It wasn't the support I was expecting, if I'm being honest. That's interesting. Gandhi, what were you expecting? I'm curious now.
So the fact they're using MS, so the document says that for those practices that have said that they want support with telephony, they will have access to use MS Teams-based calling to provide that telephony support through internet-based calling. To be honest, I'm a bit surprised I haven't gone to any of the providers that do this and that do this really well as well, to say, actually, we will give you the contracts to provide this support, because not only does that help with the temporary issues, it probably helps with the longer term, because that's the key thing with the document. It states that this support for MS Teams-based calling is going to stop in April 23. Then that raises the questions, what do you do after April 23? Now, maybe it's a temporary measure that means that they can switch it on, switch it off really quickly, and they've got a mass agreement with MS Teams to do this, which is possible. I'm still not quite sure how you do this, to be honest, and it requires you to clearly have a decent internet connection, which for many of the places that are likely to need this support is because they don't have a decent internet connection in the first place. But hey, it's one that I would definitely like to know more about. And if there is anybody out there that can explain it to us in more detail, please let us know. We're happy to have you on the string to explain it to everybody else out there in primary care. But it's an interesting one, but it wasn't what I was expecting.
Yeah, I think I didn't know what to expect. I'm really encouraged by this actually, because as a practice, we have been talking actually just in the last few months about remote working and people making outgoing calls. So GPs, some of the practice nurses have been comfortable throughout the pandemic, hiding the number on their mobile telephone, making calls, and they've often been on unlimited call programs. So that's not really been an issue, but we're beginning to see lots of our reception staff being fit for work, but just not able to physically be in the building, and administrative staff. And we've actually had the rollout of, we're participating in a virtual desktop rollout, for example. Cool. System 1 internet allows people to use their home machines to do work in the System 1 environment, for example. But we've been hitting a stumbling block around outgoing calls from people. It does say that this team support is actually just specifically for outgoing calls, and people will use their existing systems for incoming calls. But I think this could be really, really useful for us right now. So I'm quite pleased to see it. I suspect they're restricting it to MS Teams just for a get it rolled out quickly in time of pandemic. This means we can avoid usual procurement and competition rules about how we get things in place. And we'll probably see a lot of people relying on this sort of technology in 2023. And there might be a really good market for some of these companies to move into at that time. Although many people will have a bit of lock-in in terms of their processes being designed around MS Teams. But interesting. I found that quite an interesting detail.
And clearly the fact that MS Teams is one of the only provides that allows encrypted, secure patient-level communication through that system. I think you're right. That's probably the ease of use to doing it. It's a quicker contract to enact and stuff, because obviously, as you said, they may have had to go out for procurement and stuff. I'm just surprised that with the month and a half they've had, not approaching some of the more established providers about this for the longer term thing. But again, it's not a criticism as such. It's just a bit of my own personal surprise. Let's put it that way. Yeah,
and I thought this is actually okay. NHS England still moving fast on technology.
Yes,
which is good to see.
Definitely.
So, and then there's some details here about how people. I don't recall previously expressing an interest in this though. I think there was an opportunity to do that previously. So people who have previously expressed an interest are automatically enrolled in this. You can contact this number if you no longer wish to proceed. You can email them on this email address. But what about if you want to jump in or just check that you're on board with this? I'm not seeing details there of that. Hopefully they'll be forthcoming soon.
Okay, so moving down, and then the next steps is simply to sign up to the phase 3 COVID vaccinations if you're interested in this. The deadline for that, and this is where our apology came from, was yesterday. So if you haven't done that already, sorry,
it may be too late. It probably is too late. Although this document came out on the 8th, so the turnaround times here again are crazy fast.
Yes,
from NHS England.
Yeah, so it does speak to that. So we're going to just go into a little bit more detail on the QoF stuff. Just before we do that, we're going to take Jack's comment, which I think is a really sensible and appropriate one. So Jack Jacobs mentions it's not clear what view CQC will take if practices have got behind with QoF with routine inspections resume. As with everything, none of the whole oversight supervision stuff is ever commented on. I completely understand Jack's hesitations and suspicions here. They're definitely mine as well. I think it'll be interesting to see what happens when CQC come round in a year or two's time. No answers, I'm afraid.
It's a good question. I mean, I wonder whether these documents and edicts from NHS England provide air cover for practices in terms of having reduced historic QoF performance when people start looking again. I wouldn't take that necessarily as a given.
Yeah. I think the key point is if that was to be an issue, you just clearly cite the fact that we had this letter on the 7th of December from NHS England telling us that we can stop doing this in the view of vaccinating our population, which is what we focused on. And here's our plans for how we did it. Just keep it somewhere for when you need it. That will be my view. But hey, again, I don't speak for NHS England.
So appendices. And I guess we won't read through every one of them, but just give a flavour of what's in the appendices for people and sort of scroll through. But we're just done a summary of what's continuing, what's protected, and what's paid in full. I'm going to let you talk us through that, Gandhi.
No problem. So the QoF parts that you have to continue with. Okay, so this is the stuff you still have to do. And in total, it's split into 3 different sections. So the first is 75 points, which is for vaccinations and screening. Okay, so any of the QoF indicators relating to vaccination, so your childhood hymns, those kind of things, you have to continue with, and you're still being marked up based on the original QoF criteria, and they're in the appendices. So if you want to have a look, it goes into more detail. Andy's scrolling through them, as you can see, and same with screening. So that's the first lot. You have to continue. Well, you will still be paid based on your achievements of those QoF ratings. That's 75 points in total. The next one is the prescribing QoF. So this is about, let's go down to it, the various different prescribing indicators. So this is things like prescribing statins for coronary heart disease, ACE inhibitors for kidney function, DOACs and antiplatelet drugs for post-stroke patients, AF, all those kind of indicators. And in total, this is 90 points worth of QoF income that you're still being evaluated against and paid based on your achievement of those QoF criteria. The final one is maintaining your disease registers, which comes up to a total of 81 QoF points. And this is just simply making sure you've got a register of patients with a variety of different health conditions. So patients with previous TIAs, patients with AF, patients with epilepsy, dementia, all those kind of disease registers. To be honest, that sounds sensible to me. I know the prescribing one's probably going to be one that patients, practices and stuff get a little bit antsy about because it still requires a significant workload. But I can understand why they've said this. So vaccinations clearly sound sensible because the priority is vaccinate. And same with screening. They don't want the cancer time bomb hitting us even harder. Yeah, it's reasonable, but I can definitely understand why some people would be asking for have complete protection. You can take this either way, I think.
Yeah, I think they have to strike a balance here. Care has to continue, and they need to have an eye on prescribing, I guess, or we do, and they need to motivate that in some way. I think some areas will be looking at this depending on how they're deploying the vaccination and how stretched they are, and thinking it looks reasonable. Some will be thinking, no, we need more protection and more help, It's difficult because those areas that are maybe coping better perhaps don't need that level of protection and could still be motivated to push themselves to achieve the QoF indicators and be more on top of these things.
And whether the prescribing ones are born out of the fact that compared to when COVID first hit us and everything was suspended, obviously we've had potential increases in things like network-based staff, so particularly pharmacists that can do some of this work to support practices and things. So maybe that's a reason. Important to know that this 46 points extra. Okay, so just to reiterate what this is, so there are 46 QoF points relating to certain activity that there's no historic data for NHS England to compare practices against. So I think they've come up with a sensible-ish solution. Again, there's definitely going to be people out there who say, well, just roll it in, But what they've done, rather than roll it in, is that they've rolled it into the prescribing QoF indicators to emphasize that you need to sort your prescribing out. So it kind of makes, my understanding is that prescribing QoF indicator is worth a lot more. And in total, so 90 plus 46, that's 136 QoF points. That is a huge amount of QoF income for practices. So, absolute focus on that area probably needs to be there for many practices and stuff. What are your thoughts, Andy?
Yeah, if there's not historical data, they have to find a sensible way of dealing with that. And they can either give it you for free, I guess, or they can connect it to something else. And they've chosen to connect it to the prescribing indicators. And I'm not going to quarrel with that. They had to come down one way or the other. That's the way they've come, and it adds increased motivation for those prescribing indicators. But at least you don't have to grapple with 46 new QoF points associated with new indicators at this point.
Okay. So that's the work you still have to do in part. Okay, so when you combine the 46 with the prescribing ones, that's stuff you still have to do. What's protected? Well, in total, there's 315 QoF points that are protected, but that is split into two different parts. So 244 of those QoF points are protected based on your achievements for 1819. Okay, and then 71 points are protected based on 1920. And the easiest way I can say this, basically anything related to diabetes and hypertension is protected at 1920 rates, and everything else, apart from the last criteria that we're going to talk about, is protected on 1819 rates. So for practice managers out there, This will give you a rough estimation of what you're going to hit QoF income wise. So you can present that to your partners and partners that do QoF leads and stuff. That's the key stuff you need to know to have an idea of what QoF income you're going to have, because there's probably patients out there thinking, why are we talking about QoF income? Okay. The reality is, aside from the GMS contracts or the capitation-based income that practices have, QoF is the biggest fund that practices have in order to do the work that they do. If they don't have it, it can lead to significant changes in staffing and quality, because it's that much of the income that practices have. So knowing how stable that is, if practices don't have this income, that can mean the difference between a practice shutting and stuff. So yeah, important to know that key thing.
Yeah, no, very important, Gandhi. Thanks for making that point. So we'll just scroll on down to the bottom of the document. But I think you've described those last two segments in good detail, Gandhi. So I think people should be able to walk away with a good idea of what's in the document, what the key points are, and what the structure is. But it's obviously important as you're planning in your practice in your primary care network to spend some time with the actual document.
And then the final one is the QoF QI, which is 74 points that you're being paid in full. So you don't have to do anything for it. You will get the full amount of what will be eligible for QoF. So that at least is what practice judges guaranteed income from QoF and stuff. So that's QoF in a nutshell. Any thoughts, Andy?
Yeah, as I said earlier, I think it's actually good that we've got some protection of income. I think some people were wondering if we wouldn't. So I think that's good. And I think in some areas it'll strike the right balance. In other areas, it won't be enough. And in some areas, people may be saying it's too much protection for general practice. I don't think that'll be many areas.
No.
But they're trying to strike that balance, aren't they?
Yeah.
Yeah. How about yourself, Gandhi? What do you think overall in terms of the
I think,
level of the measures?
Like you say, people will view it very differently. I think, John, I think, makes a really good point that there's an emerging overlap between IAF and QoF indicators, which can be really confusing, and particularly the vaccination part. So flu vaccination is both technically in IAF and it's also partly in practice level workload in terms of, so it is a bit confusing in terms of how practice can estimate their income that they're going to get from that. And again, like we said, this income is what makes practice continue running. It pays for staff, So being aware of that is really challenging. I think it's reasonable. I probably would have liked to have seen a little bit more towards securing of the income personally, if they're asking us, because the thing to remember is that many practices are still going to be doing this workload. And a lot of this is based on repurposing the staff to deliver vaccinations, but they still have to review the patient. So from a prescribing perspective, for a patient with diabetes, yes, they're saying that from long-term condition management, I don't have to manage them because I'm not being paid. The funding is secure, which is great. Still have to do the workload because otherwise that patient's going to deteriorate potentially. Then there's the safety element of it, making sure that they're still okay. And fair enough. Prescribing is still work that you have to do, but it is just those elements of, clinical safety is a key part of this. So practice is still going to be doing some of this workload. They can't just repurpose everything to vaccinations.
What would you have done this differently in any way, Gandhi?
I'm so glad I'm not.
It's a big question.
It is a big question.
I've sprung it on you. It's not in the script.
No, fair enough. I think it's a reasonable. My perspective is it's a reasonable compromise. There's definitely parts I probably would have tweaked and adjusted, and probably and then I'm a GP. I probably would have liked it a bit more favor of more security and stuff. The one thing I would have asked for is an actual estimation of what we're being asked to do in compensation for this. So what NHS England haven't said is they said repurpose the work to doing vaccinations. There is stuff in there that we're hearing about practices being monitored as to how much vaccination stuff they're being done, but there's no criteria about figures and that kind of stuff. It's just help, which is some way positive thing. But I guess the flip side is we don't know how much we have to do. And, it's that element of when you're taking stuff away from another place suddenly, and the impact it's going to have in a year or two's time by not doing this work is the part I think a lot of practice are going to hesitate with. A bit more clarity in terms of what that's going to look like.
Yeah, that does lead to a lot of variation in the fragmentation of what should be
Absolutely.
happening at CCG level. So this is where you hear about different CCGs in different parts of the country, often taking very different lines with their practices, and that makes things really quite confusing for people. So yeah, I think that's a good call. It's an unenviable job actually to negotiate and put these things in place, and I'm not sure I necessarily have coherent suggestions as to how it could be done better. I'd be interested if John's still watching. I'm wondering, do you have any theories as to why there's an overlap between IAF and QoF? Because it is obviously it's not random. People are doing this, and there may be some thought behind doing that, because they could associate IAF targets with other things. Don't know, do you have any theories, Gandhi? I think it's an interesting observation that we've made before.
So I've been quite vocal that I am not a big fan of some of the IAF criteria, and particularly the fact that vaccinations were rolled into IAF. I feel is actually damaging in terms of health inequalities, because it rewards the places that can do vaccinations really, really well. It's taken that income away from those practices and put it into a network scenario. So actually there's less inclusion in some places, and particularly those networks where they're still learning how to work together. And let's be honest, often that can be networks where health inequalities are at their deepest. So I'm still very vocal in fact. I think the vaccination IAF criteria is actually quite damaging to networks where there are significant health inequalities. That's my personal view, because it has produced so many additional challenges over a difficult time to try and achieve that for practices, and removing their income, and meaning basically they're going to have less money to do the work in the first place. That's being echoed with COVID. The areas where COVID boosters are harder to achieve, again, are those areas of health inequalities, particularly when you've got multiple ethnicities, deprivation, those factors we are seeing. That's why there's so much focus to try and help them. It seems designed, unfortunately, by either design or by unintention, that it's, in my view, it's not working. But that's my personal view.
I think there's probably a broader move to move your more mass vaccinations like flu away from practices into more of a community level delivery. I think NHS England is becoming neutral as to where those, or clearly are neutral as to where those vaccinations take place, and don't consider them core to GP activity anymore, and just want jabs in arms. And whether that's done by community pharmacy, by the primary care network, or by practices, I think they don't care. And I think they perhaps believe it might be done better at community level. So I think I've got my conspiracy hat on there. I think it's a manoeuvre to remove these activities from general practice.
But then if that's the aim, then they need to be crystal clear about it, so practice can plan the budgeting and the workforce that they've got, because actually they're still saying to practice, but we want you to vaccinate everybody as much as possible. But then if they're providing other opportunities for patients to do it, which is great, choice is good, don't get me wrong, but that has a massive impact on practice income, which then impacts workforce, which then impacts sustainability. It destabilizes places. The vaccination income in some places is so significant that it can destabilize their staff, because that could be the cost of a nurse potentially. If you don't have a nurse to do all this stuff, well then yes, you can repurpose, but again, be clear.
I think in some places it will stay with general practice, but I think NHS England, my perception is that they are kind of site of delivery neutral, and that's the space that they're moving to with vaccinations, and that's what I think is behind the inclusion in IF potentially. And
interestingly, John's made another comment. I wonder whether the longer term intention isn't to move practice-based QoF into PCN-based IIF. No conspiracy theories there whatsoever, but yeah.
You may well be right, John. They do look very similar, and there is overlap, so that is a very, very good theory.
Partly because it would force practice to focus more on the PCN role, which is seen as a way forward from the centre. Andy, I believe you just said that.
Yeah.
So thank you for capturing that in another way, John. Helpful.
John, do you think this is positive or negative? You're obviously paying attention to what we're saying.
Definitely. And thank you for that, John. We love the comments and stuff. So just whilst we give John the opportunity to respond, we're going to move on to the next topic. So we've talked about the QoF changes. Hopefully that's been a really useful guide for you all. We're just going to spend a couple of minutes talking about some of the other changes that have happened wider than general practice in particular. So that's talking about Plan B. Andy, what do you know about Plan B?
I know. So Plan B. So there's going to be an increased. So this is a response to Omicron coming along and increasing cases, and the concern amongst the Health Service Government, Public Health England, and more widely around the world about the impact that this will have on health services and people over Christmas. It's good to see the government moving more quickly than they have done in the past, before there's a perceived emergency within the public. So that's really positive. And I gather there's going to be an increased emphasis on the use of vaccine passports, on the use of masks. And Gandhi, I think you jotted down the specifics here before we came in. I'm going to hand over to you problem, because you've got them in front of you.
Yes. So just to be clear, there's a couple of things that you need to be aware of. So there are different deadlines as well, one of which has lapsed today. So the first one, and probably the most controversial one for many people, is the fact that mask wearing is back in more detail. So it's now masks is in shops, public transports, and most indoor areas. Emphasis for those people that may have forgotten this: healthcare environments, masks never went away. You still had to wear masks in healthcare environments. That's not changed. So indoor environments has always included healthcare delivery. So practices, hospitals, community centres, for example, that deliver healthcare, that is to continue. In terms of the types of masks, so we've had a comment from, I can't say the name, Jitin Verma. He's talking about FFP2 masks, or FFP3 masks, sorry. So again, there's no clarity on this. It just says masks and facial coverings. I know many people have been questioning why hasn't NHS England, particularly for healthcare environments, instructed the use of FFP2 masks at the very least to protect healthcare workers, because actually, if Omicron is as virulent as it could be, and more importantly, damaging as it could be, if we have a stripping out of our workforce at winter time, ain't going to go well, is it? But hey, the instructions have just been simple, fluid-resistant masks and stuff to continue.
I was having a conversation about the grade of masks in the practice the other day, because people were asking about N95 and FFP3, and obviously they're still not available, still not mandated for use in any but certain aerosol generation procedure settings. And a member of staff was just reflecting of, when you look at pictures of people in the Black Death, in the plague, in the olden days, and people are wearing sort of funny, masks with beaks on, where they've got potpourri and things like that in. And we were reflecting that in 100 years time, 50 years time, we might look back on this and think, why were people wearing pieces of cloth on their face, thinking that they would get significant protection from a global viral pandemic? Bit of a segue, but I'm interested to see how history will pick apart the response to the pandemic and the sorts of equipment that we've been using.
True.
Anyway,
but just to emphasize on that point, so as of yesterday, 10th of December, mask wearing was pretty much back in all indoor environments and public transport. The second deadline, which was the working from home. So it's not as well supported as previous elements of some of the COVID changes. So things like furlough and that kind of stuff are not back yet. Whether that changes, we will see what happens. But effectively, the instruction is, if you can work from home, you work from home. And there should be measures made to support people working from home. How much support and measures isn't clear at all. Interestingly, obviously, for the past few weeks, general practice has taken an absolute beating from certain parts of the media about seeing people remotely. And now we're being told to go back to remote working. And yet there's absolutely no comments on that whatsoever in the media. I'm waiting for that to happen again in about a week or so's time, just before Christmas. People saying, I can't see my GP there again. But hey, we will see. And then the final one, which is a deadline that's so this starts on the 15th of December, so that's next Wednesday. Vaccine passports usage is going to be significantly increased. So clubs and venues greater than 500 people, any unseated outdoor area greater than 4,000 people, or any large venue greater than 10,000 people. So I think they're thinking football stadiums, sports venues, that kind of stuff. You will have to either show your COVID vaccination passport or proof of a negative test result, like a LFT or PCR, depending on your situations. And if you want to know how to access your passport, Andy, if you want to switch it over, you're more than welcome to check out this quick little video that we've got on EGP Learning that shows you in under a few minutes how to access your vaccination certificate. So dead easy to do through the NHS app. You do need the NHS app. Alternately, you can ring 119 for a copy, but they are time limited. Important to remember that. There is often a deadline with those kind of things as to when it has to be redone, shall we say.
Yeah, needs to be recent. Gandhi, as we're wrapping up, I've got a few questions for you. Did you guys have a Christmas party?
We were due to have one. And in fact, I think we are still carrying on with it in a different form. However, we have massively changed the way that's going to happen. So it is being held in our practice waiting room on Tuesday, I believe. It is limited capacity as well. So we've told the staff we can only have certain numbers of people because we've got downstairs, we've got a giant library. So there's a massive space there that we can host it in. Masks as ever in our building. Negative LFT test, otherwise you can't come in as usual. And yeah, it'll be a very short, sharp affair. We felt it was important. Clearly, if things change, we may have to stop that. I know many places have stopped having Christmas parties, unlike in certain government areas.
I was going to ask you, did you have a Christmas party last year?
No, last year, like everybody else, we protected our patients and we protected our staff by having remote parties and not engaging with breaches of the COVID regulations, unlike potentially some other areas of our society. And I'm aware that we're not going to talk about in more detail in case we get ourselves in more hot water. However,
we try and stay apolitical, just about on this show. I know we were due to have a party last night, and we cancelled the party. It was interesting that actually, I think everybody was in a way relieved that we didn't go ahead with it. Actually. I don't think there was any member of staff that didn't say, actually, I was kind of thinking that it might be cancelled, and actually I don't really mind that it was cancelled this year. And we are putting something else in place. I think it'll just be a simple gathering just during work time, do a bit of Secret Santa. So
one thing we did cancel, however, so one of my partners is actually retiring, and so we cancelled her retirement party just because that was due to be at her home, and obviously that was a different setting and not the ability to do the sensible stuff that we needed to do, which is a shame. Partner that's been in the practice for over 27 years, but the aim is that we will reschedule that hopefully for the summer when things are a bit different.
Postponed, than
yes, not Good. So that's everything we were hoping to cover in today's episode. Just a slight little update in terms of what we've got planned for the next few weeks from eGP Learning. So just to be aware that this is the last time I think me and Andy are going live this year. However, we have got some amazing content coming for you, including our eGP Learning General Practice Awards, which will be coming out in a couple of weeks' time, as well as some additional content in terms of engaging with your PCN staff before we come back to you next year with ever more content and commentary. Maybe if there's something really significant, we might jump in potentially, time allowing, but we are taking a bit of a break over Christmas and New Year's just to collect ourselves and make sure that we come back to you fresh and able to do all this stuff, hopefully.
John has just given us a comment. I haven't read it, but it's long, and it might just be worth putting on screen because he's obviously put some time into it.
Wow. Okay, that is a big comment. Okay, so I am our local PCN director. I have divided loyalties. Getting engagement from our constituent practice can be difficult, so maybe more IIF is a good thing. Troubles me that it appears to be all a bit policy on the hoof. I am also concerned that the effectiveness of the PCN model has not been properly evaluated. Yeah,
I think that's fair.
That's a lot there.
That's a lot. I think that's a very balanced position and being very responsible in terms of declaring conflicts of interest there. And I think we're in very similar positions, aren't we, as well? And actually, I feel the same. PCNs are not tried and tested, and there is an awful lot being put upon and within them in a really short period of time during a national emergency. You just wonder if it's all properly planned and conceived. So is it on the hoof? Good question.
I think important to recognise there has absolutely been an element of adaptation that the NHS England and various other organisations both had to do, because kind of COVID was never a planned event and our response to COVID is clearly challenged. But definitely a valid comment, John. I can understand it. Me and Andy, both PCN directors, and definitely at times I've questioned how effective it can be, and the changes that happen. But thank you for the comment, and also for the final one. That thank you for your excellent broadcast this year. Really appreciate it. We love hearing positive comments. We love hearing critical comments as well. Actually, it gives us an opportunity to change and adapt and stuff. And if you do have any comments, definitely let us know down below. We love to hear all this kind of stuff as ever. Andy, any final comments for 2021?
Oh, goodness me. I think it's been a really kind of tough, strange year again, hasn't it? So I think thanks for all of those people who've been joining us on the broadcasts, and yeah, for supportive and critical, comments about improvement. Just thank you for people's engagement, really, and thanks, Gandhi, for keeping going throughout the year and keep a momentum with EGP learning.
Thank you, and to all of our listeners and stuff and viewers, absolutely have loved having you join us. Pending the numbers, we're probably going to hit 8,000 subscribers just before Christmas, to be honest. So that will be an amazing milestone for us to reach. Thank you, Andy, for supporting me throughout the past year in terms of delivering all of this, and it's been amazing fun. I really enjoyed it. And we will catch you next year as we continue to try and tech enhance your primary care and learning. Catch you later.